Hello there, everyone. Good afternoon. My name is Sarah Hunstead. I am a paediatric nurse, mum of two, and founder of CPR Kids. And at CPR Kids, we empower parents and families with the life-saving skills of baby and child first aid and also recognition of sick child. And today I am excited again to have Laura from Cub Care with us. Laura is a paediatric emergency physician, and I will let her introduce herself because she will do a better job than I will. I might talk too long, so go for it, Laura.
Great. Thanks, Sarah, and thank you for having me again. It was so much fun last week that we agreed we'd do one, hopefully a bit shorter, so apologies, and well done for those of you who made it to the end last week. So as you said, so I'm a paediatric emergency physician, and I work in a children's emergency and for Cub Care, who do urgent paediatric consults starting very soon. I'm a mother of two boys who I'd love to say if I have a bit of bags today, that's because we were partying at 3 a.m. this morning. Thank you to my youngest.
And yeah, so don't worry about that.
Really excited to be here today, and we're going to talk about ear pain, which I believe you've had lots and lots of questions in the past, so hopefully we can answer them all.
Yep, absolutely. So what we would like you to do is, while you are on with us, feel free to ask your questions. Type them in the comments below and we will get to them as we go through. So don't worry if we haven't answered it straight away. We do have had, goodness, where is my brain this morning? It hasn't quite connected with my tongue, I don't think. So we have had questions already as well. So Laura, what do you think we need to start off with? I mean, I guess one question is how do you even know if your child has ear pain or not?
So that actually can be quite a challenge. And so it depends the age of the child really. And, obviously the younger children can't communicate as well, whereas older children might be able to say that they've got ear pain. So in younger children, people say that they can notice them tugging their ears, which, isn't always a very definite sign that they've got ear pain, and they may just be irritable, their behavior may be unchanged. And so I suppose on that note, being honest, I think we talked about this last week, is when my son was about 7 months old, for a few days he just wasn't quite self. He seemed to be in pain. I was giving him Nurofen, and and he'd get better a bit, not so good overnight, and it was only a few days later where he had some pus coming out of his ear that we realized he'd had an ear infection. So it can be really tricky because you kind of think you'd like to think as a doctor and all this, but so it can be hard. But
I know, same, exactly the same. One of my daughters, she had she had multiple episodes of being irritable, ended up GP referred us to ENT, try and see what's going on. The ENT guy, ear, nose and throat specialist, said to me, Sarah, her eardrums are quite scarred. She's had multiple ear infections. She never had the pus, but she had, certainly other things. Yeah. And even as a nurse, I didn't realise either. So, guys, honestly, that's one of those things where something's wrong and you've got to trust your gut, and you just have to go and see an expert about it. Okay.
Yeah, definitely.
All right, good. Okay. So what else do we need to know?
So I suppose then, what are the causes of ear pain? And there's actually a lot, and I think it's probably easier to put it into sort of the age brackets. So you've kind of got the younger, the preschool age children, so under 5, where babies, it's not common for them to have ear issues. I suppose probably the most common reason that a young baby would have ear pain would be from referred pain from teething, and again, probably that's we all know the challenges of working out whether they're teething. It does so many different things. And so in those younger children, it can be from a acute infection, so what we call an otitis media, and I'll go through what the different causes are first, and then I think we were going to focus on what are the differences between an otitis media and otitis externa. Sorry. So we will talk about that, and I'm going to do some dodgy drawing. And then children like to put things in places that they're not supposed to, so a foreign body. So if a child's put something in there, so that's, and you don't always know that. Have they got otitis media with an effusion? So they got fluid behind the ear, and often the most common thing. So have they got a viral respiratory infection in the upper airways, and just again referred pain. So if you've got glands up in your neck when you've got an infection, that can cause make you look like you have pain in your ears. So they're probably and that's the most common in the younger children. In older children, they get a lot less ear infections in the middle ear, but they get a lot more of the, like, we call it swimmer's ear, so otitis externa. And then even just wax buildup can actually cause a lot of pain. Trauma to the ear, so the cotton buds, you know, putting those in your ear or anything, yeah. So basically, nothing should go in there.
Nothing and smaller than your elbow should go into your ear or your child's ear.
Yeah. And then referred pain again. So, you know, the body's quite interesting that you can feel pain in one area, but actually can be from somewhere completely different. So if you've got jaw pain, so dental from teeth, like if you've got teeth infections or abscesses, or issues with your the jawbone, like jaw joint there, then you can have pain in your ear. So they're probably the most common things.
Yeah, and so we really need to realise that it isn't always infection, that it can be another cause, and so that's why we can't just automatically presume that. So I think that's another important reason why, if you suspect that your child is in pain, that you are taking them to a doctor to have that checked out. Yeah. So you did mention otitis media and otitis externa there. Can you explain to us what that is and what the differences are?
Yeah. So in medicine, we make things sound really complicated so that we make ourselves sound clever. And it's probably not as as difficult as you think. So apologies for my drawing. I am by no way an artist, but I'm going to attempt to do a drawing to explain and hopefully make it a lot clearer in people's minds. Okay. So I'm just going to draw the ear. Let's make sure.
That's already
so this is the outer ear here. This is the ear canal. So this is what we call, this is your eardrum. So when we look in the ear, so we have I'm sure people are probably familiar, we call it an otoscope. It's so the what we can use in your doctor's surgery to look in the ear. This is what we're doing. We're putting the thing here and having a look down this ear canal, and then we're having a look at the drum there. And then behind here, this is where all your hearing little bits are, and I'm not very good at drawing them at all. And then this bit is joined. So people probably don't realise that actually your ears, your nose and your throat are all joined up, which explains why when people have a viral upper respiratory infection, they can often have, you know, they have snot from their nose, they have a sore throat, they have ear pain, because it's all linked up. So you have your ear canal here. So I'm going to get a different colour now. So this being your ear canal, this bit here to your drum, to out here, this is the outer ear.
Excellent. Just lift it up a little bit more, Laura, so we can see it a bit better. There we go. Yep. Okay.
There we go. And this bit here would be your middle.
Okay.
So otitis, you know, referring to the ear. So when we say externa, so external, so externa is here, this bit in the canal there, and media being middle, it's here. So what happens is you get infection in here, and because this canal here joins up to the back of your nose, so the theory is what most likely happens is children get a viral infection. Again, why younger children are so much more prone to it is, you know, they're meeting bugs for the first time, especially more common in children who are at daycare. Yeah. They have smaller tubes, you know, they have smaller everything because they are, you know, smaller. So there can be some swelling, infection here, and then you can get a blockage here, and then you can get infection, which may be a virus, maybe a bacteria. And so otitis media is when you have an infection of this bit of the middle ear here. And so when we look down and have a look, we can look at the eardrum, and it's basically, you know, like a lens to the inside of the ear. And so we can see certain changes. It might be bulging, it may be red, and that shows that there's fluid, or that you can even see the fluid behind there, and you can tell that there's infection there. When you have infection of the outer bit, that's when you have a look, and you see like basically pus and yucky stuff all in this bit here. So this is what we call swimmer's ear, so much more common for older children who go swimming lots, and that, you know, the ear hasn't dried and you've got bugs or some trauma from there. Whereas, so these are probably the older children get this, the younger children get this one here. the complicated bit, and this is what my son had, so he obviously had a infection of the middle ear here. And then because there was so much pressure there, which is why it's so painful, and you know, ear infections are really, really painful for children, and we'll talk about the management of that later, because it's pressing on the drum here, and that's very sensitive. Eventually, if there's blockage here and it can't drain to the back of the throat and the nose, this may actually perforate, and so there might be a little hole here. So for him, he had pain, and then it went because the pressure was so high, and then the next thing we had pus coming out of his ear, and actually that made him feel a lot better. And in children who have that, they normally feel much better afterwards because the pain's gone down because it's naturally been relieved.
Okay,
I think I'll stop there for the moment.
Yeah, so that's actually great, because we actually just received a question: what happens if fluid or pus does come out of the ear? And I think you've actually just answered that really nicely, to be honest. That sometimes it can be that perforation of the eardrum. It's that release. I've had my daughter at 3 a.m. screaming in my arms because the pain is so bad, and then it finally perforates, and I hear her just sinking and falling asleep with all the pus dripping out of the ear. So exactly that. So if the fluid or the pus does come out of the ear, it's just so important that you are seeing the doctor to be able to figure out, is it that outer ear infection? Is it that middle ear infection? What do they need to have? So thank you very much, Georgia, for that.
And I think on that note, if it is the inner ear infection that has perforated, then generally that is an indication for antibiotics, which again we'll talk about later. So that and then they need to be checked on later on to make sure that that little hole does heal, which most of the time it does.
Excellent. While we're on the subject of antibiotics, certainly one of the earlier questions that we got was, does my child need antibiotics if they have an ear infection? Can you answer that one for us, or is that a very tricky one to answer?
No, I've done a lot of reading before this, and I had it clear, and then it's a little bit muddy. Look, I think most of the guidelines say it has to be acute. So it has, for children to have had symptoms less than 48 hours, by definition, to meet a diagnosis of acute otitis media, because you can get chronic kind of inner ear infections. And the guidelines sort of say if they're under 6 months, yes, antibiotics are generally indicated. If they have a perforation, yes. If they're kind of in that age, sort of a bit older, you can wait and see. Over probably about 60% will have the pain will have settled and the symptoms will be getting better within about 24 hours. If after 48 hours they've still got pain and symptoms and fever and things, then that's when normally we would consider giving antibiotics. And so I suppose the reason we don't give them straight off is because we don't know. Often it's a combination of viral, bacterial causes, and they say majority will resolve without antibiotics.
Right.
And for all of those parents out there, we know that yes, if we want to make things better, we would give the treatment, but at the same point, there are challenges with giving children medication. There are side effects. So with the antibiotics, they can get vomiting, diarrhea. So, it's always in medicine, it's always a balancing act of what's the benefit of the treatment versus the risks and the side effects. So, so generally not always indicated. So you can, watch and wait and see. But if it's ongoing after 48 hours, most of the time people would then, offer a course of antibiotics.
Got it. So if I was to take my child to the GP says to me, look, their ear is just a bit red. Let's just wait for another 24 hours. Let's see what's happening. That's completely reasonable.
That is absolutely fine. And some doctors will give a prescription for some antibiotics and say to the parents, if in 2 days' time the symptoms are ongoing, then start them on this, or they might want to get you to come back, and that's kind of a doctor preference.
Yeah. And that's the other thing as well, is that if you feel like your child is getting worse, whether it's with ear pain or any other illness, the important thing is that you do go back, because as we were saying last week, children can change very quickly. And so therefore, sometimes a lot of it is watching and waiting, but if they are changing, they're not getting better, they're getting worse, it's important to seek that help.
And I think following on from that, actually one thing I wanted to talk about, so we talked about last week red flags. So if your child has an acute inner ear infection, red flags to watch out for is if they get redness or swelling behind the ear. That can be a sign that the infection spread to the bone behind the ear, so they definitely need to be seen. And if they have symptoms. So we were talking last week about headache. Are they acting abnormal behavior? Have they got have they got any abnormal signs? So have they got like a droop on one side of their face, normally on the same side as the infection? Have they got light sensitivity? So they've got headache and they really don't like the light. Then again, that's sort of a red flag for, you know, more serious infection, and go to the hospital and get them reviewed.
Yeah, absolutely. I think that's very, very important. So what can you actually do? Your child has got ear pain. You've been to the GP or to the hospital, whatever it is that you've needed to do, depending on how unwell your child is, and they've got the antibiotics, but they are still in pain. Yeah. What can you actually do to help that?
Yeah. So I suppose if we split it up into, you've got, we call pharmacological, so medicines that you can use, so pain relief. And the two main ones would be paracetamol, so Panadol, which you can give four times a day, so every sort of 4 to 6 hours. And you can give ibuprofen or Nurofen, and that can be every 6 to 8 hours, 3 times a day. I think there's been some studies that have shown there is a little bit of a pain is better managed with ibuprofen because it has an anti-inflammatory as well as pain relieving properties. So they're probably your two main pain relief that we would use. We don't really use Pain Stop anymore. I think, the days have gone where we just realise the side effects outweigh the benefits of that. Occasionally, if children in really severe pain, and this would be, if they've been up to the hospital and the pain's just not relieved with that, we might think of something like oxycodone. But yeah, normally paracetamol and ibuprofen, either you can give them at the same time or you can kind of alternate them. I've always been a big fan of Nurofen before bedtime when they've just had their dinner, because it lasts a bit longer, so hopefully you get a bit of a decent sleep. And then you've got your non-medicine stuff, so relieving the pressure, so having them sat upright. Unfortunately, that might be that they're sleeping on you in a chair overnight. Heat. I think we undervalue the benefit of even heat packs or a warm compress on the ear. And there was a third one. I'm trying to think what it was. That lots of cuddles and I think they're yeah.
And I think that one of the important things to remember there is we are talking about alternating paracetamol and ibuprofen here. We're talking for pain. So this is about pain. Fever is a different kettle of fish. We're going to park that over there, okay? We'll save that for when we do fever, okay? But right now we are talking about pain relief, particularly ear pain relief in children. Now, certainly ear pain can be excruciating. I've suffered from it as an adult, and, it's awful. But, I can remember years and years ago being at triage in the emergency department and kids coming in at 2 o'clock in the morning, screaming, inconsolable, holding their breath, because the parents just couldn't believe that it was from a simple honestly can be excruciating. I had to do my time in the adults emergency, and I saw many adults with teeth and ear pain in the middle of night as well. And it's, I suppose, just to explain why that pain is normally worse at night, and that's often my theory is that, and I think this is some scientific bit, is that your body's steroid levels naturally drop overnight, which is again why we see lots of respiratory things. And so with anything with inflammation and swelling, when your steroid levels drop, then they get worse, and that's why the pain's so bad at night. Yep, absolutely. Yep, and of course. And one of the, just looking at some of the questions that we've received as well, Alison has had a great suggestion for us as well. Alison has suggested that distraction can be actually a good thing, obviously in combination with the other things as the pain is starting to get relieved. I think that's probably a great idea.
Totally agree, Alison.
Nothing, I tell you what, that is when you're getting the iPad out. 100%, absolutely. And Lee has also just said, is a heat pack okay for pain, which you just mentioned as well. So yes, absolutely. But one of the important things that we need to remember when it comes to heat packs, follow the directions on there.
Yeah.
When you heat it up as well. Be careful in the microwave. Be testing it first. If you're using a gel pack, it's really, really important to make sure that it doesn't have hot spots in it and that you are not putting it directly onto your child's skin. That's really, really important, that it is wrapped in something. So yes, a heat pack is okay for pain, but please be careful and be watching them as well with it. That's an important thing, because burns from heat packs is something that we actually do see regularly from kids as well. Now, Jenna has also asked us a question as well. So Jenna has actually said that her 19-month-old daughter always seems to have quite a bit of wax coming out of her ears. Is that a normal thing?
Yes, that's ditto. So yeah, that everyone makes different amounts of wax, and that's absolutely fine. I suppose the main thing is if it's coming out and it's on the outer bit, you can just, you know, wipe it there, but definitely advice is not to be putting cotton tips or anything down there. But yeah, that's completely
Absolutely. It's one of the problems with the cotton tips is, number one, you can cause trauma, and number two, it can also impact that wax as well. So ears are amazing, aren't they? How they actually self-cleaning. That's what that wax does. It migrates out. And so one of the, you know, we've got inbuilt cleaning. We don't need the other stuff.
Yeah, and body's very clever.
It is. It's incredibly clever. So I think that is a good thing. Now, just while we're here, does anybody else have any questions? Now is the time to be typing them in the comments below while we are live, to be able to answer that. And let me have a look. Here we go. We do have more. I knew there would be here. So let's see. Lee has actually asked as well, pressure on the sore ear. So laying the sore ear down. Now, I know certainly that when my daughter has had ear infections, she's had otitis media and otitis externa, anything even thinking about touching her ear with the otitis externa, she would scream. We had to actually lay her on a travel pillow because she insisted on laying that side. She couldn't lay on the other side, of course. But we had to use a travel pillow with a hole in it for her to be able to lay down, and that was right. But what would you recommend?
I think it would be finding the position that really is most comfortable for them. That makes complete sense, especially if it's a inner ear infection, because when you're lying on the side of that infection, it's putting pressure on the drum. So I would have thought anatomically, if you're on the opposite side, then it's helping move the fluid down that eustachian tube to relieve it and help move that there. But then again, if it's in the outer ear, maybe actually having it so that the pus and the gunk coming out will, you know, probably put a towel on the pillow, because it's going to be pretty gross.
Yeah, absolutely. Yeah, it does get pretty gross, doesn't it? So Jessie has a question for us as well. Jessie has asked, what are grommets? So
so they are basically like how your body can naturally make a little hole in the drum. What the ear, nose and throat surgeons do is they put those into the drum, into that membrane. Hang on, I'll get my drawing up again, into that drum there. So you put, hang on, let's get a different color. And they're literally like little tiny plastic tubes. I hope no ENT surgeons are watching here. And they put them through the drum there. And so the idea is that they can relieve fluid here. Now, I haven't really touched on, and it was one of the things I did want to mention, and I was surprised no one had asked about yet, is that what glue ear, which is probably the most common reason that people have grommets put in for. And what that is we talked about having an acute infection, which is when you have fever, pain, and you've got infection behind the ear, and that's, you know, and they're more unwell and have a lot of pain. Some children get otitis media, so middle ear infection with an effusion, so they have fluid behind as more of a chronic thing, and that's, you know, and often comes on after an acute episode. So after that, they sort of have fluid behind there. Or it can be children who've had recurrent ear infections, again, because it's not draining, so there can be a bit of swelling there, and you'll constantly have fluid behind the ear. Now, they won't have fevers, they won't have all the other stuff, they may still have ear pain. And the issue with that is that it can impact their hearing, because your hearing vesicles are inside here, and what happens is you a noise, you hear the sound, it goes here, and then it gets sort of whatever the drum does. God, seriously, ear, nose and throat surgeons, do not watch this. And the hearing vesicles then pick up that and then send a message to your brain. And so if you've got fluid here, that's going to impact your hearing. So actually one of the ways, and this might happen with my brother when he was a lot younger, as my mother kept taking him to doctors saying his speech is, he's delayed with his speech, and they didn't pick up till quite late on that he was having chronic glue ear, so inner ear infection, sort of like more with effusion, and he then had grommets put in to drain that fluid away, and then after that it will improve and their language will pick up. So it is a reason if children do have a language delay, and you're really noticing that they don't seem to be, and you're having concerns about their hearing, they should get a hearing test, they should see your GP, and they can always get referred to see a paediatrician or an ear, nose and throat specialist.
Yeah,
I hope that explains what grommets were, but I thought it would, to why they're actually put in.
Yeah, I think that was a absolutely fantastic explanation. It really was. I think one of the best things, just this little side note, I'm going off on a tangent here, but I think one of the best things that doctors can do when explaining something is draw a picture. I really do. I think it is absolutely one of the best things. I think it just helps us understand everything.
Yeah.
Now
that's how I learn. So.
Yeah, I learned that way too. Absolutely, lots of colour. Colour helps.
Yeah.
So there is a question here from Cheryl, which I think you have just answered as well, and that is best age to get tonsils out. Daughter companies for ears. That's going and seeing an ENT surgeon definitely.
Yeah.
See your GP. Yeah. Get a referral to an ear, nose and throat doctor. Ask around, with other people's experience, who they've gone and seen. I think that is a great thing to do, is ask other parents about who they've seen and make an appointment with a GP and get a referral. I think that's a thing to do because, I think it's a tricky one to answer because of so many other factors in there.
Yeah. And I think, you have to realise that it is common for children, especially young children who go to daycare, and as a mother of two who both at daycare, I know this to be a fact, that they do get recurrent illnesses, and that is normal. So for a child who is at daycare, they can have 1 to 2 viral illnesses a month. So that's, if you look at year, that's 12 to 20, and so most of the time they will grow out of that. And I'm glad to say, my 3.5-year-old, we're getting to the stage now that we're not, there's a point in your life where you talk about when they're not snotty versus actually, they've got a snotty nose, so the youngest one, we're still at the he's not snotty today, wow, that's so I think it is really common, but it depends what symptoms they're having, if it is recurrent tonsillitis or if there's other reasons. So if they're getting episodes where it's affecting their sleep and it's affecting their breathing at night and they stop breathing, then that's a reason to see your GP and get referred.
Yeah, absolutely. No, that's right. And by the way, that Don Egan said, he saved her entire family. That is a good thing. We need that. We absolutely do. So I will just double check and see if there are any other questions at the moment. I think we have answered everything, and we have. 30 minutes is up already. I know, I can't believe it. We could talk. I'm sure we could actually sit here and have a really good chat for at least a couple of hours. Definitely. But definitely. Laura, is there anything that you would like to recap, or anything that you would like to say in addition before we finish up today?
I don't think so. I think really, like how we said last week, if you're really worried, get them seen. And if things change and you get them in the car and they're in severe pain because they've woken at 1 in the morning, and you get to the hospital and they're fine, that's okay. We know that in medicine, in pediatrics things change, and we'd much rather, if you're worried, take them to get them seen.
Yeah, that's right. That's exactly right. So just to recap, exactly that, babies and children can have ear pain. There can be multiple different causes, whether it be trauma, whether it be a foreign body in the ear, whether it be infection. There are different types of infection that affect different parts of the ear, that sometimes it's not simple differentiating what's actually causing pain in your child or where it is. So it's important to trust your gut and see your doctor. That's really important. They don't necessarily always need antibiotics or need something straight away as well. And there are things that you can do to help your child's ear pain, from over-the-counter pain-relieving medicines, and remembering to always follow the directions on the bottle. Go by your child's weight. If your child's weight is quite above or different from the average, then speak with your pharmacist or your GP to find out what their ideal dosage is. That's an important thing. And always follow the directions on the bottle. And of course, cuddles, having them upright, warm compresses, not too hot and not directly on the skin as well, can also be helpful, as well as distraction. So that wraps us up.
Good summary, Sarah.
No, all good. So that wraps us up for the day. It has been an absolute pleasure talking with you, Laura. You are
you too. Thanks.
Of information. Please join us again. And what we would love you out there to do is type in the comments below, not only tagging somebody who you think will benefit from this information, but also what subjects would you like us to talk about? Because remember, we are here to give good evidence-based information for you, so you don't have to wade through everything, or with Dr. Google as well, trying to pick which one is good and which isn't. Okay, so that's why we are here. So comment down below. We will see you again very, very soon. Make sure you go to the Cub Care page and the CPR Kids pages to know when we're about to do this. But one thing I would like you to do just before we finish is, can you just explain to everybody what Cub Care is and how access? That would be great.
Okay, so Cub Care, we're a team of acute paediatric emergency physicians who have decided that, you know, we want to try and fill a gap that's out there, especially in the evening. So we want to do some urgent paediatric telehealth consults, and we haven't started yet, but we're going live very soon, I can tell you now. So we're doing the test and, you know, making sure we're as prepared at the moment. And so the idea is you can either get referred by your GP or self-refer. Obviously, you know, there will be a bit of a cost from that if you do have to self-refer, but that you will be seeing a paediatric emergency physician, so a consultant level, who will be able to see you. You know, you can be at home like we are today. You know, and dialing in the evening, especially because that's always when everything happens, isn't it? You know, it's just the worst timing, and you're like, oh my God, do we get a hospital? We can't get our GPs closed, but you know, they've had a head injury or they've got a fever now, you know, and I'm really worried and I want to get them checked out. Yeah, they've got ear pain and I'd like to get them checked out. And that's what we're really trying to hope to fill that gap, so that people, you know, we can see children and their families and, you know, help make that assessment and see, do they need to go to emergency at 10, 12 at night? Because, you know, as much as we love our jobs and, you know, being there 24 hours, we know that families, it's a real big thing for families to get themselves up to the emergency department as well, or sitting in and waiting for an after hours GP all the time. So I hope that gives a good explanation of what it is. So yeah, there's a good group of us and we're really keen, and you know, we all love our job and we love looking after children and their families, and you know, we just want to make things, I suppose, more easily accessible.
Absolutely. And I think it's an absolutely brilliant service. It's so good. So thank you.
No, yeah. So, and I know, you know, having done some time out working in Mackay, that, you know, I think when we live in our cities, it's very, you think, oh, you know, yes, having recently had to go to the ED, it's, you know, it's still a big thing when you've got other children and logistics. But, you know, I've had people who used to have to drive 2 hours to come and see me in the emergency. So if we can make those families, you know, have access, and I think try and minimize that gap as well throughout the country, that's, you know, that's a big thing that I'd like to do.
Absolutely. That's absolutely fantastic. Alison has just asked, is Cub Care Australia-wide? It's telehealth. You can be anywhere.
Yeah, definitely. Yeah, I know. That's I haven't got my head around the time for things when that all changes.
Yeah, don't worry. Yeah, exactly. We'll deal with that when it happens.
Yeah.
All right. Okay, so we are going to sign off now. Thank you, everyone, for joining us.
Thanks, Sarah.
And we will see you again very soon. Thank you, Laura. See you soon. Bye, everyone.
Bye.